And for box 2, we have very good friends of mine, Dr. Keshavamurthy B. and Dr. K.U. Natarajan. Keshavamurthy is a senior intervention cardiologist, my colleague at Tanjavur. He is one of the high volume operators, has done more than 5,000 angioplasties, and an excellent thinker, and then he has a lot of innovative procedures designed by himself. We all adore him for this. And we have Dr. K.U. Natarajan, the past HOD of Amrita Hospitals, Cochin, for the Department of Cardiology, a very great person, very nice man who has more than 20 to 25 years of experience in complex coronary intervention and good experience in rota and vessel closure, and a very good electrophysiologist too. I hereby request the moderators to take over the session and go ahead with today's proceeding.
Dr. Keshavamurthy, you can unmute. Keshavamurthy, you can unmute. All right.
Good evening. Good evening, sir.
Yeah, please go ahead.
Yeah, yes, thank you. So today, I thank Dr. Selvamanni for giving me the opportunity to moderate this session, along with Dr. K. Natarajan, sir. And it's a very important session. Of course, calcium is the most important factor for under expansion, and under expansion is the most important reason for MACE. So, conquering calcium is like conquering coronary interventions. And with the advent of IVL, there is a light at the end of a tunnel, and it's like we may overcome calcium in future. We have today, for the discussion, we have an expert panel. We have Dr. Barua, who is a Director of Interventional Cardiology at Apollo Hospital, Visakhapatnam. And he is known for his complex coronary interventions, including left main interventions and other imaging-aided interventions. And we have Dr. Rajesh Kapoor, he is a Vice Chairman of Medanta Medicity, Vice Chairman Cardiology of Medanta Medicity Hospital in NCR, Delhi. And he is a great interventional cardiologist with a lot of experience. And we have Dr. Samir Dani, who is known for his yearly conference, New Pencil Interventions in Gujarat. He has received a lot of awards from the Gujarat government, and I welcome all of you. And of course, we have Dr. K. Natarajan as a co-moderator. Shall we go for the first talk, sir?
Yes, sir. Please let us go.
Yeah. We have Dr. Sambat Kumar, who will be talking on muscular and calcium, and he is my colleague at Madurai Meenakshi Hospital. He's a senior interventional cardiologist with 20 years of experience in cardiology. I request Dr. Sambat Kumar to go.
Thank you. Is my slides visible to everybody?
Yeah, visible.
Yeah. Thank you. Good evening. And I thank Dr. Selvamanni for giving me this opportunity. And it is nice to see Keshav. He's my good friend for a long time. And it's very nice to see Dr. Natarajan also. Dr. Natarajan may not remember me, but I was once his student for 15 days. DNB cardiology student for 15 days in Amrita. And then I left. And then got DM, and that's my story with him. But anyway, nice to see you, sir. Good evening. And I am presenting a small case, how I encountered a calcium in a PCI, and how I got fooled by the images, and how I managed to escape from the case, from the complications. And this one was a 53-year-old male. He was an hypertensive, non-diabetic. He presented with chest pain of a few days duration, and his ECG showed T inversions in anterior leads suggesting end STEMI. His tropi was positive. His echo showed normal LV function. His CAG showed single vessel LAD disease. He underwent it. They tried PTCA in another hospital, and the oral report given by the patient was they couldn't dilate with the balloon, and so he came back to us for a second opinion. And that time I didn't have any the angio and the angioplasty done by the previous operator. So I thought I just had a paper report, and I told him to come back, and he got admitted, and this was the angiogram. The LAD had a significant stenosis, and it looked like some hazy and like an ulcerated lesion, and it was looking like a thrombus, partially recanalized LAD like, and with a tight stenosis. Of course, I could see some calcium in the LAD in that particular place, but initially I thought this is more of a thrombotic lesion with underlying calcium, and because the presentation was ACS, tropi positive, and this looked like some ulcerated thrombotic lesion. And I went ahead. This was the spider view, and wired the lesion. And when I tried to balloon it with a 2 mm balloon, it was not yielding. Then I tried with a 2 mm NC balloon, and we can see that there was a very tight lesion, and the lesion was not yielding. It looked like a figure of 8, and with an NC balloon, it was not opening up. Then I tried a cutting balloon. The cutting balloon wouldn't cross the lesion at all. So I couldn't do anything with a cutting balloon. So next option only left us to open the, to make the passage better. I tried the Scoreflex. Scoreflex, it tried, it could cross, but still it wouldn't relieve the lesion. And there was still a nice waste, and beyond the lesion was not, we couldn't cross it with higher Scoreflex or a cutting balloon. It was still looking tight, and the hazy lesion was still there in the proximal LAD. So this was an ACS. It looked like an ulcerated thrombotic lesion, but it was undilatable with a balloon. So it's a thick calcium. So the only option which was left was to do a rotablation. Did a rotablation with a 1.5 mm balloon burr, and luckily with that 1.5 mm burr, with a few minutes of pecking, I could cross the lesion, and as we can see, the rota has opened up the lesion. And after that, this was the angiogram after the rota burr. And we can clearly see that the lumen has become better. And after that, I wanted to see what was the lesion and how much was the calcium. So this was the OCT run after the rota burr, and it's all a lot of dissection created by the ballooning and the rota. And then there was a 360-degree calcium with a tight stenosis, and it was full of calcium, long segment 360-degree calcium. And this calcium was the one which was preventing the balloon expansion of that vessel. And after this rota, I could pass a balloon, and this time I used a OPN balloon. And OPN balloon also, there was some waste, but with prolonged inflation and higher atmospheres, the lesion gave way nicely. As we can see, it opened up nicely with the OPN balloon, 3O OPN balloon. And after the OPN balloon, this was the angiogram. We can see the lesion has opened up very nicely. After that, I did one more OCT to see the calcium fractures and all. And we can see from in the side pictures in the at the level of the calcified lesions, here we can see nice fractures in the calcium in 2-3 places. And the angio-wise also, the lumen was very good. So after that, I proceeded with the stenting and stented. The lesion was mostly from the ostial LAD, so I stented from the left main to the LAD with a long Zine stent. And this was the OCT, post-procedure OCT. After the stenting, there was good expansion and good MSA, and there was no distal complications. And the circumflex ostium also was well preserved, though there was already some minimal disease in the circumflex ostium. And post-procedure also there is some little bit pinching of the circumflex ostium. The flow was very good, so I left it like that. And this was the post-procedure post-stent angiogram. So as we can see in this, from this case, calcified lesions also can present as acute coronary syndrome. Acute coronary syndrome need not be always thrombotic. Even a calcified lesion can present as acute coronary syndrome. The angio picture may look like a thrombotic lesion, and the severity of the calcium, though in this case we could see some calcium in the angio itself, I didn't expect this much severe calcium in the angiogram. And only by OCT imaging I could see this calcium as very 360-degree full calcium. And because of that OCT, I could see the calcium, and I could do the plaque modification by ROTA. And without ROTA and OCT, I couldn't have been successful in this case. So my take-home message is ACS doesn't mean that lesion will be very soft. It can be calcified. The calcium can be a masquerading feature in this, like in this case. And PTCA of a calcified lesion is a very, very demanding and complex interventional procedure, and imaging is a must, and plaque modification is often necessary. Thank you.
Thank you, Dr. Sampath, for that excellent presentation. I remember you very well when you came to Amrita.
Ah, that's nice. Thank you.
As you very correctly said in your take home, the last slide, very dangerously eccentric lesions which only have a small track. One of the important differential diagnoses is severe eccentric calcification, as you very correctly said in your conclusion slide. It can be as mild as some thrombotic lesion, which is easily amenable to angioplasty. And the very fact that the previous center could not accomplish the procedure itself means that one of the close differential diagnoses is calcium. What was the depth of the calcification on your OCT imaging, Sampath? The depth of calcification, how many microns was the depth?
It was almost like a 50 to 100 microns, something like that. I didn't.
It was only superficial. It was superficial only. Superficial only,
not very deep. The place where it was tight, it was only superficial, but circumferential all over the, I mean, all 360 degree.
Nice take message. You said calcium does not necessarily mean stable lesion. Some of these lesions can be ruptured and they can cause acute coronary syndrome, as you very correctly said. This particular case, short of rotablation, I don't think you would have, there is any way we could have successfully done this case. So it is a beautiful demonstration of the value of considering the possibility of a calcified lesion in acute coronary syndrome, especially when you have such a dangerously eccentric with only a small track available. Calcium is a distinct possibility. You may miss it in the fluoroscopy, but keep in mind that calcium can be there. And rotablation definitely helped your case, and imaging definitely was a good diagnostic procedure in this case. Keshavamurthy, want to say something?
Yes.
You have to unmute yourself. Unmute.
Yeah, I'd like to add something.
Let Dr. Keshavamurthy say, and then you can come. Yeah. You are unmuted. You have to unmute.
Keshav, you have to unmute.
You consider doing a coronary CT before taking the case, because some center has failed to open it up. Is it?
Yes.
Actually, Keshav, the coronary CT, I don't think it can give you an idea about internal calcification or probably non-luminal calcification. Probably it will just give you a calcium score. And in this case, it was a very discrete calcium just specified to one area, 360 degrees calcium, which was not allowing. Do you think there is a role for the CT angio in that thing? I'm not very sure.
Yeah, CT angio can show some calcified coronary arteries, but when you do angiogram, it need not be that severe and all. Calcium, what we see in CT angiogram is mostly the outer calcium, not the inner calcium. And even
it is actually very useful in CTOs, probably where you cannot, the contrast is not going with only the length of the lesion, and then probably their calcification and all will be helpful. But such a case with ACS, where I don't think so there is a role for CT angio.
Okay, Rajneesh, you wanted to say something?
Yeah, Rajneesh.
I think Dr. Sampath, very nicely done case. So congrats for that. Just a very good message which comes out is after rota, you again use the OPN balloon. I think that's the very good message. Until you break the residual stenosis totally, I think you should wait and try your best effort and then get a stent in. So otherwise one keeps on struggling. You put a stent and there's a residual stenosis. That's one. And second, suppose even after using OPN after rota, there is still a residual stenosis, then the role of IVL handy in this. So we have done many cases where we have used both as well as IVL, especially.
Point well taken. And the most important point that you said, which I liked the most, was always dilate after in a very bad calcific disease which needs rotablation. It's always good to pre-dilate with the balloon as big as the final stent that you're going to put. It can be anything. It can be any balloon, but you should, if it is a 3 millimeter vessel, dilate with a 3 millimeter balloon. Make sure that the balloon has fully opened before we take the stent. That is very, very well taken point. We'll move on to the next case, Dr. Keshavamurthy.
Yeah. We'll go forward to the next case. Next presenter will be Dr. Sarita Rao. She's a senior intervention cardiologist at Apollo Hospitals, Indore. Please start your presentation, madam.
Am I audible?
Yeah.
So good evening, ladies and gentlemen. Special good evening to Dr. Rajneesh Kapoor, whom I'm seeing after a long time. And good evening to Dr. Samir Dani. We meet again on an online forum again within a month's time. So my topic today is coronary calcium, the three musketeers. So plaques, they do reduce vessel distensibility and impair the uniform balloon dilatation, subsequent stent expansion. Various technologies, as we have been discussing, have been developed in order to tackle this problem, and rotational atherectomy long being considered an adequate choice for plaque preparation when dealing with highly calcific lesions or even after balloon failure. However, in larger vessels and in lesions that are not so tight, the burrs might not be able to ablate the plaque. And if at all, it only modifies the intimal calcification and doesn't deal with the circumferential calcification. So I will discuss in short a couple of case-based presentations of 3 of the most successful devices in the armory to deal with these calcified lesions, of which 2 are relatively newer kids on the block. So the challenges of treating calcified coronary lesions is that when you look at this data of about 7,000 patients and you see the risk of death, MI, revascularization and MACE, you would find that the outcomes are worse after doing calcified lesions. The calcium scoring system, which we were just discussing, would be based on the angulation, the thickness, and the length. And the neo-intimal calcification, it predicts a new stent expansion. So in my first case, nothing seemed to be right over here. So this was an anomalous left main coronary artery arising from the right coronary sinus, having a calcified lesion which had failed after a procedure about a month ago at another center. Now this was just before IVL had come in. So backup was the real issue in this case. So we took a buddy balloon, the buddy wire, a 2 into 10 millimeter balloon didn't dilate the lesion. You can see the dog boning there. A 2.5 non-compliant balloon failed to cross. So 2 passes of a 1.5 burr rota was done. Post rota, we were able to cross with the 2.5 balloon, but the lesion did not heal even with 20 atmospheres of pressure. Subsequently, we were able to get a stent through after dilatation with the 2.5 non-compliant balloon. But even after dilating the stent, there was dog moaning suggestive of circumferential calcium. So later the OPNNC was negotiated and it was inflated. And the stent was finally dilated with it at 38 atmospheres of pressure. And this was the final result. So the do's and don'ts with the OPNNC: avoid the polymer sleeved wires. For distal lesions, use extra support. For pre-dilatation, usually we use a 0.5 millimeter lesser sized balloon. And for a post-dilatation, a 1:1. Increase pressure gradually after 20 atmospheres leads to uniform dilatation, avoids unnecessary overinflation, and avoid any air inside the balloon, which is very important as it leads to rupture and also air embolism. So the OPNNC, a twin layer balloon, is very useful in our cases. And in this particular case, my learning points were that the buddy balloon helped in stabilizing the guide. The serial dilatation followed by rota ablation helped us to deliver the stent. And OPNNC did the trick of final expansion. Now, using it inside the stent acted like a high pressure cutting balloon with which we could yield the circumferential calcium. Now, subsequently, IVL was launched. And this was actually one of our first cases with the IVL, and the crane comes with the clique. So in this particular patient, he was a 78-year-old gentleman with eccentric calcified mid-LAD disease. He had presented with an inferior wall myocardial infarction, and we had done a primary angioplasty to the RCA. And the next day we took him for an angioplasty to the LAD. So you can see the calcified lesion in the LAD. This was the IVL first run. Recrossing with the IVL balloon after the first run was smooth. This is the second run. Notice as we are giving further pulses, there is serial dilatation. This was the fourth pulse. And post 4 pulses of IVL, we had an adequate bed prepared. The stent crossed smoothly. And this was the final result. So intravascular lithotripsy inspired by urological applications and designed for now cardiovascular calcium. Now this was a first case of IVL, and we were much relieved to know that now we don't have to push rota in many of the calcific lesions and many times deal with the complications which occur when we use rota ablation. So we became quite aggressive and started using intravascular lithotripsy in a lot of cases. And the good times, they don't last long. And here we stumbled into hard rock. This was a 67-year-old gentleman, inferior wall MI, ejection fraction of 45%, recurrent angina, lately unstable. His angiogram revealed critical triple vessel disease, with a huge chunk of calcium in all the arteries, and he categorically denied for a bypass surgery. He had a codominant circumflex, proximal 80% eccentric lesion, which was okay, but he had a heavily calcified LAD with a mid-distal 80 to 90% calcific stenosis. You can see the calcification along the entire length of the LAD. He had a codominant RC, which was a CTO. So 2 into 10 millimeter balloon was negotiated across, remained undilated. There was dog boning. Distal lesion, we were able to close. However, we were not very successful in being able to dilate it. So we took in the IVL, and in the first dilatation, there was partial dilatation followed by rupture of the IVL balloon. Now, this is a problem which occurs with the IVL. So we had a problem at hand. We needed a second balloon, and that too, it is quite expensive. At my center, at Apollo Indore, it costs about 2,85,000. So again, you have to speak to the patient. But luckily for us in this situation, the company people provided us one more free of cost. So the second IVL balloon successfully dilated the lesion. Second IVL pulse. Post-IVL, we were able to have an adequate bed prepared for the stent delivery. Distal lesion was dilated with 2 into 10 non-compliant balloon. Now, after that, when we took the stent, again, it was not negotiating around the bend. As you can notice, there's playing of the wires while we are pushing. So again, we dilated with a 2.515 non-compliant balloon. Still, the stent did not cross, so guideliner had to be taken to deliver the stent. Mid part of the stent was still indented. This is just to show the amount of calcium in the coronaries. You can see that. L6 was also a calcific lesion dealt with OPNNC post-IVL. Mid-distal stent was deployed with these subsequently. And finally, post-dilated with an OPNNC 3 into 15. And this was the final result. So the various ways in which to treat calcium, first is the assessment, important as we were talking about the CT, the angiographic, and the IVS methods. Then if we do have suggestion of heavy calcification with greater angle, thickness, and length, then we would look at all the methods of calcium modification, including an NC balloon, an IVL, rotor ablation, and use of guideliner. So my assertions in this case were that too much of calcium is very tough to crack. And although IVL has simplified the process, so has OPNNC, which are now the most physician-friendly tool at this time. Rotor ablation, however, still finds a place where the IVL balloon cannot be crossed because it is quite bulky. And there is good chance of IVL balloon rupturing by the calcium spur, and incidental cost is also steep. So we suggest that to start an initial IVL burst, just proximal or just little distal to the maximal calcification, and later when the calcium at the spur melts down, give the IVL pulse at the most calcified area to avoid a balloon rupture. IVL and OPNNC are the two newer innovations to complement the age-old but risky and tricky rota to work in tandem to tackle calcium, which is the Achilles heel of an angioplasty. These three cases demonstrate that different subsets of patients may require any one or a combination of all three musketeers to tackle the tough calcified lesions in the coronaries. Ladies and gentlemen, thank you so much.
Presentation, madam, especially the third case is very educative. I just wanted to ask you, what will you do with rota undilatable calcium? If you can't dilate a lesion with rota, if no balloon passes, what will you do? What will you do? How do you manage that?
So if I'm not able to deal with the lesion post rota?
Yeah.
So see, normally whenever
rota
I'm
doesn't
doing,
cross.
what if the rota doesn't cross?
Yeah.
So generally, see, that problem we encounter with IVL. Usually with rota, we are most of the times able to cross. But I think you have to take a smaller sized burr if you're not being able to cross the lesion. And most of the times with rota, we are able to cross. What is your experience? It is IVL which is difficult to cross with. not the
Yeah,
original.
IVL will not work because you can't cross the balloon because the rotor
If you
itself will
can't
not cross
cross
it.
it, yeah.
So, have you ever thought of using a bigger size burr in undilatable lesion, rotor undilated lesion? Will you normally we downsize the burr size? Is there any chance? Does it work like if you upsize the burr in case if the rotor doesn't cross?
I've always tried to downsize the burr size when it doesn't cross, but I've never actually tried to upsize it. Have you done that?
No, there are some reports that I've seen somewhere. So I just wanted to ask you. Thank you. Thank you. Yeah, we have Dr. Rajnish Kapoor has got some questions. Dr. Barua has got some questions.
Can I answer your thing? So that's a very tedious situation if the rota bar is not crossing. That's something very tricky situation, and we usually confront such situations in our day-to-day practice. So there are two ways. One, first troubleshooting is that change your wire from a floppy rota wire to a smooth rota wire. That is very well mentioned, and that should be done first of all. And then the revolutions per minute. If you are initially trying at 170, 180 RPM, decrease the revolutions per minute. Try using at 120 to 130 and constant packing and keep it on. Keep trying knocking at the calcified lesion again and again. These are the only ways by which you can actually conquer the undilatable rota lesions. Obviously, from once you say undilatable rota lesions, I'm assuming that IVL balloon cannot grow. But these are two methods by which we can conquer this. And Dr. Rao, it's a very well done cases, and it's pretty nice to see you after a long time.
Thank you.
Dr. Barua, you have some questions?
Yeah, actually, this is a very nice case, Dr. Rao. Excellent demonstration of all these techniques of calcium treatment in coronaries. Actually, what regarding the rota, when it is undilatable or uncrossable, I think one single point you need to be very careful when there is a acute band and rota is not crossing. At that point of time, of course, as I already mentioned, that you can increase the revolution as well as switch over to a more support wire. But still, you need to be very careful when there is a acute band. So with suddenly high speed or high revolution, if you go, sometimes there is a chance that you can get perfect. But we'll be very careful by multiple packing movement, slowly, probably. Undersize the bird also on what you told. I think that is another important thing to do that. I just wanted to ask you.
Yes, I fully agree.
Yes.
I fully agree with you in that whenever there is an acute bend and we are going it with rota, we have to be very careful because it is at that bend point that suddenly there can be a deflection and there can be a deflection or a dissection at that point.
Yes.
So when there is a
yes. One thing I want to ask you, we have done so many complex cases that do you think that sometimes imaging will be useful, especially third case, because many a time in spite of whatever you do for calcium, still there are some areas stent may not get kind of deployed properly or expanded properly. So imaging is very useful. I think this kind of heavily calcium long lesions, I think if you can utilize the imaging, I think that will give a further kind of enhance the benefit, I think, in this kind of case.
Sir, we are running behind time. I think we'll go to the next presentation. Dr. Arvind Sharma can answer. He has some point to make that he can do it with his talk. Dr. Arvind Sharma, please go ahead.
Yeah, actually, we had a case day before wherein we had CTO, heavily calcified CTO crossed with Gaia 3. There was an Z band there, and we could not cross it with rota. In that process, we had a wire cut through. The wire was lying in the LAD, and to our surprise, when we passed another wire and dilated, the lesion dilated like nothing was there. So sometimes these bends can fool us down very heavily, and what we are trying and doing, thinking it is a calcified lesion, may not be so actually. So
the wire itself must have got bent.
Sir, no, wire did not break from there. We thought we'll downgrade the rota burr. So we were just trying to take the burr out. Accidentally, the wire got cut in the left aorta actually. The guide came out and the wire was cut at the aorta. We tried snaring it out, did not come out. Fortunately, went distally into the LED, so we stented across the whole of the wire.
No, sometimes one of the reasons why the burr does not cross, I'm sorry I'm taking your time, is because the wire gets kinked at a Z bend and then your burr does not cross. So if you take the wire in distally separate, I think you please present, no problem, we'll discuss it later.
This is again a case which has already been presented. It's almost similar. This was a 53-year-old male. The first ECG from the referred place was acute anterior wall MI, hyperacute. By the time he reached us, the ECG looked to be normal. The patient had only mild chest pain. The pain has significantly diseased, so I called it an aborted MI. LV was also normal and the patient was non-diabetic, hemodynamically stable. These were the angiograms. RCA appeared to be fine. Circ was okay. And LAD had a long lesion starting after the second diagonal. The tightest portion was at the mid to distal LAD junction. So this is what it looked like in cranial. The tightest lesion is somewhere here. So if we can notice, the wire is getting biased and it is moving always towards the septal. It was a real tricky thing to cross the wire into the LED. I'll show you how it went. It was a real nasty bend wherein we had troubles getting the wire into the LED. That bend was a really tight, nasty bend, and the wire would always go into the other side. It was looking like a routine normal angioplasty, except that difficulty in crossing this mid LED lesion, which again, after a little bit of struggle, possibly as a micro catheter would have given us a little more better control, but somehow you can see the way the wire is entering into the LED. So we went ahead. A 1.2 wire could not go. So I went with the 10 smallest balloon and dilated it. 105 balloon we could dilate. Then 1.25 balloon and again a 20 balloon distally, which opened reasonably. But if we notice 2.5 NC balloon could not open here. The main lesion was in the distal part of the LED, but the tightest calcific spot was here. So there was dog boning which was noticed. We tried to upgrade the balloon and it still did not work there. And now we can, when we just had a look, there is a calcium here, but it was not looking that horrible to begin with. So then the second problem we had was while taking the balloon out, the accidentally the scrub nurse pulled the wire also out, and the wire was out in a dissect, and there was a significant dissection distally, and we had a wire which was floating in mid LED. So again, it was a tricky thing to cross this lesion distally. And we tried with the polymer jacketed wire. Then for the more better direction control, used a Gaia 2 wire. Again, there was dissection we can see right from above downwards everywhere. And with lot of difficulties, finally we could get our wire in. And see, we can see how the wire is moving now. This was another Xion blue, which was shaped, and finally we could negotiate that Xion blue wire with a little difficulty. The Gaia did not provide us enough control, but somehow luckily Xion blue, after almost 45 minutes of struggle, could get in. Then we passed the micro catheter, and then it was a clear case of rota ablation. So there was no second thought about the that part. So we did a rota with a 1.5 burr, 850 rotations per minute, required around 1.5 minutes of burring to pass the lesion, and then we dilated with a 2.5 and a 3O balloon to crack the calcium, which opened well, and it was confirmed in multiple views that there is no eccentrically not, I mean, there is no place wherein it has not opened well. So then it was difficult to negotiate the stent here. So we did a balloon assisted tracking of guidezilla. You can see that inflating a balloon over which the guidezilla was gradually inch formed, and subsequently we could pass at 2.75 into 48 millimeter Zions expedition stent, which opened up nicely except that middle part. And then we put a 3O into 28 millimeter Zions expedition stent again in the proximal segment, which again opened nicely. Post dilatation was done in the very proximal segment with a 3.5 balloon, and in the middle and distal segment with a 3O balloon and 2.75 balloon distally. So again, we required guidezilla support to cross this mid LAD. The final result was good. We got valve area, sorry, a minimal stent area of 7.41, 7.24, and 4.9185 square millimeter in proximal and mid LAD, which was quite acceptable. Then there was an issue of slow flow. Possibly there was some thrombotic component also, which led to slow flow distally. The IVUS did not show any dissection or anything, so we gave a lot of vasodilators. Usually we would perfuse the vasodilators with the micro catheter. So distally, nitroprusside, nicoran, adenosine, everything was given. And this was the final result which we got. There was no dissection which was noted, and there was TIMI3 flow which we could achieve. So this was the final shoot, which shows well flowing LAD, and there is reasonable open stent. So the hardware which we used here was XB 3.57 French run through Xion Blue, Filter XT Gaia 2 wire, and a Grand Slam wire to help us in the get us a good support to deliver our hardware.
Dr.
Even
Arvind,
with
Dr. Arvind Sharma, we have
Yes,
two more
sir.
presentations. Can you just quickly wind up, please?
Yes, sir. I'm just done.
Yes.
Regarding the lesson learned, never underestimate calcium and tortuous coronaries. For balloon unditable lesion, early switching over to rota is better. And rota can be done in ACS situation, even in minor dissections are there with reasonable safety and good outcomes. Dissection in calcific and tortuous vessels, specifically if they occur at bends, are nightmares and require a lot of patience, skill, and prayers actually to cross back into true lumen. And imaging is must. Adequate bed preparation is must in calcific lesion and may require cutting or scoring balloon 1:1 pre-dilatation with NC balloon at high pressure despite successful rota ablation. Thank you.
Thank you very much. Excellent, really challenging case that you did. Only one point I thought which is worth mentioning is whenever you use a guide liner to take your stent to the LAD, especially in the mid-distal junction, and you are eventually also going to stent the LAD proximally because of pre-existing lesion. And if you see the ostial segment of the LAD, which we finally did not have a stent, what will be that length of that segment roughly, Arvind?
Around 16 millimeters or so, 14, 16 millimeters.
See, a lot of times this guide liner, when you take, it can always induce trauma to the endothelium. And especially when you're going to stent the proximal LAD, it may not be a wrong idea to start from the ostium. That's what I felt. Because now there is a small segment of LAD which is not stented. Am I right?
Yeah, it's almost 10, 12, but that was looking normal.
I know, but this guide liner can theoretically harm the endothelium. And now that you are stenting, another 10 millimeters of stent you could have had a more peaceful night that day. That's what I meant.
Sure.
Okay. So we are already well beyond our time. We have two more presentations and we have only 15 minutes left. So we go on to the next presentation by my good friend, Dr. Jabir. Are you there?
Yes, yes. Shall I share?
No, let me have the pleasure of introducing you.
Oh, go ahead,
You can
please.
reduce your presentation to 5 minutes. I'll introduce for the next 5 minutes. So Jabir is my very good friend.
All right,
He's a
all right.
consultant cardiologist at Lisi Hospital in Cochin. He has a lot of experience in imaging, particularly OCT imaging, and he has a lot of experience with calcium rotablation. He has done live cases in the India Live with calcified disease, etc. So to Dr. Jabir, who will speak about the role of guide liner. We already had the previous case which Dr. Aravind showed the use of a guide liner. So Dr. Jabir will show the role of guide liner in long diffuse calcified disease. Over to Jabir.
Thank you. Thank you, Nataraj.
Hello.
Is it visible? Are my slides visible, Nataraj?
Yeah, very much. Please go ahead.
Okay, so I'll go. Thank you so much. So,
lecture में था बोलो.
The use of a
Call है तो बोला ना क्या हुआ?
guide extension catheters, which provides usually a coaxial alignment for increased backup support, especially in an unfavorable takeoffs, transradial approaches, anomalous vessels, anomalous origin of the vessels, or any situations with guide back out, and it helps to access the lesion when it is difficult to reach, like a complex lesions, diffuse calcium, tortuous vessels, and distal lesions. And accessibility to a distal lesion in a diffuse calcium is one of the most important uses where you can use a guide extension catheter. We have the two guide extension catheters, the guide liner as well as the guidezilla. Both of them are almost equal, except for the guidezilla has only one single size of 6 French, which has a stainless steel hypo tube. Now the recent additions, they have changed it and has got a hydrophilic bioslide instead of the silicon wipe in the guide liner. And if you look at the safety and feasibility of the guidezilla catheter in complex coronary interventions, as Dr. Nataraj was rightly pointed out, this can create problems also. So most of the thing, it is heavily calcified lesion in almost 1/3 to almost 1/3, that is 37% cases, and in 45% of the cases it was CTO. So these are the two most important indications or situations where we use a guide extension catheter. I'll show two cases. First one is a 67 years old male hypertensive who is not a diabetic with an effort angina for 6 months, a recent NSTEMI, good LV systolic function. His RCA, a huge RCA with dense calcium, tortuous RCA, and you can see the calcium which is dense and very hazy. It could be a calcific nodule also. We went ahead with a Amplatz catheter. Our major challenge was wiring the lesion. Our wires, first we used a Fielder XTA. This wire was not, it was not even reaching the major calcific area, and it was deflecting back. So we tried with the help of a microcatheter also, with the help of the microcatheter, no, we were not to try. Then we thought it's better to cross the first curve with the help of a guidezilla, and so we put in a guidezilla, and with the help of the guidezilla we could finally reach the distal part of the lesion with a wire, and we used a Tasuna 1.5 for 1.25 Tasuna to dilate the lesion first, and followed by further dilatation and the use of a IVL balloon, which was a 3.5 to 12 millimeter IVL balloon. And following which, this guide liner was so useful, it helps to wire the lesion, it helps to pass the devices, and also to pass a OCT catheter to do the OCT. And now you can see with the OCT, the lesion was well split. The calcium was, so this was before the IVL. The calcium was well split, but there was deep calcium, and so we thought of putting a IVL balloon, a 3.5 into 12 IVL balloon. The full 80 pulses were used, and after which our OCT. And now the OCT, you can see excellent luminal gain with significant split of the deep calcium. Now the lumen is well dilated and it is for deployment of the stent. and 3x38 plus a 4x38 DES were put with the help of the guidezilla with overlap. And this is the final shot, angiographically good result. And OCT wise, it's a stent which is well deployed. You can see the apposition indicator, it's fully wide. So there is no malapposition, there are no edge issues, and there is no under expansion. Initially seeing the calcific vessel, we would have expected a significant under expansion of the stent, but we could prepare the bed very well with the help of the extension catheter. We could pass in a balloon initially, subsequently an IVL, which could crack the deep calcium, provided an excellently well-prepared bed for the stent positioning as well as the stent dilatation, and finally a good result. The case 2, this is a 54-year-old female diabetic presented with effort angina, long diffuse calcific lesion in the LAD. We thought initially we can pass a balloon and dilate. We could pass the the balloons were easily crossing the lesion. We dilated with a 1.5 millimeter balloon, a 2 millimeter balloon, a 2.5 millimeter balloon. So we thought the bed is now adequately prepared, and we tried to pass the stent. The stent was not going in. So we thought initially we had difficulty in the cannulation. So we used the Judkins catheter. We changed the Judkins catheter to a extra backup catheter. And even with the extra backup catheter, the stent was not going in. The catheter was backing up. So we were stuck here. Then we thought of doing an anchoring balloon technique. We tried to anchor. Even with anchoring, the guide was backing out and the stent was not moving in. We dilated it again, and with the help of that balloon, the dilated balloon, the extension catheter, the guidezilla was passed. Then it was a cakewalk for the stent to go in. Post dilated, and pretty good result. But then if you look at the left main there, you can see some haziness. And an OCT, you could see that is what Dr. Natarajan was mentioning. The catheter can damage, it can produce endothelial damage. Not only produce endothelial damage, sometimes it can, the extension catheter can produce nasty issues. So there was a significant left main dissection. So the left main was again stented with a 4 millimeter stent, post dilated, with now she has stent from left main to LAD, but the entire stented segment appears adequately dilated, well deployed without issues. So if you look at the safety and feasibility, the guidezilla catheter in a complex coronary intervention and observational study, the most important problem, though it is of help many a times, but it should be very carefully used. The difficulty in passing the catheter can be there. Catheter complete fracture can occur, partial fracture can occur, kinking can occur. And the coronary artery dissection was to the tune of 2.5% with guidezilla and 14% with guideliner. But you can see the guideliner use was, the number was only 65 versus 408 in the guidezilla. So problems can occur with the use of extension catheter. We should be meticulously and careful. So my final thoughts on this topic are: guide extension is an invaluable tool in diffuse calcific lesions. It helps in the delivery of the device, and the device should be delivered to a well-prepared bed. That is quite important. Otherwise, we may deliver the stent, but the stent may not expand adequately and we'll be in trouble. Be careful and meticulous. And of course, keep in mind, guide extensions can create problems. The weapons are an important factor, but not the decisive one, which is man that counts. Thank you so much.
Thank you, Jabir, for those two very nice cases of demonstration of the use of guide extension catheters to accomplish a difficult calcified diffuse disease. And Dr. Keshavamurthy, want to add some points? You have to unmute yourself before you add some points. You have to unmute.
Shall we, sir, shall we go on to the next presentation because we are running out of time?
You can call the next presenter.
Yeah. I request Dr. Ajay Swami sir to go ahead and present the next study.
Thank you, Dr. Keshav. Are my slides visible?
Not yet, sir.
Are they visible now?
Yeah, yes.
Right. So first of all, my salutations to my teachers, some of whom are in the audience and some of whom are not. And thank you to Dr. Salomani for giving us this opportunity. We're supposed to look at perforation since I'm the last man standing and we're already behind time, we'll quickly go ahead. Calcium and its consequences, we'll just look at case-based scenarios. This is one patient who looks like he's got a long segment mid-LAD disease. There's some calcium, but it doesn't look so bad, but there is a nice junction between the normal and the calcified segment. What we must pay attention to. So it was approached like any other angioplasty. Wire was passed, balloon dilated. It wouldn't be covered by a single stent. The plan was to take 2 stents. This is the distal stent being deployed. You can see that there was
your audio, Dr. Ajay Swami, your audio is not good. Can you improve upon it? Maybe you can hold your mic close to your.
Am I audible now?
Now much better. Now much better.
Oh, okay. Thank you very much. So as you can see, there are 2 stents. It was decided to put in 2 stents. This is the distal stent which has been put. And as is often the case, you feel that, this has not been dilated properly. So we just pull the stent back a little bit and dilate it again with the same stent balloon, thinking that we are perfectly safe since the proximal part is inside the stent and no issue, and just see what happens. So immediately the patient complained of pain, and then a small check, which we always do when patient complains of anything, this is just a 6th sense, and this is what has happened, and this is the stage at which we are called. This is the second case, a 58-year-old hypertensive ex-smoker, chronic stable angina, recent worsening angina. And this is what his angiogram showed us. There are 2 tandem lesions with a normal segment in between, and little bit difficulty in 90% discrete with a post-stenotic dilatation, and a large diagonal from the diseased segment. A small plaque distal. Again, it is wired and pre-dilated, and the distal stent is placed because we thought there was a significant discrepancy in size. And one can see that after dilatation, the distal stent appears a little under-expanded. Again, the stent balloon is pulled back a little bit and dilated slightly higher pressure so that you don't have an edge dissection. And this is what the next shot shows us. Coronary artery perforation is a rupture and resulting in a leakage of the contents of the arterial lumen. Wires, atherotomes, balloon catheters, metallic stents, and as we have learned now, guidezillas and guide extensions can also cause this problem. 0.1 to 0.6% of coronary angioplasty. And short-term mortality is horrible, 5 to 10% of cases. The ones that we are really worried about is the type 3, the frank contrast medium extravasation into the pericardium through an orifice of more than 1 millimeter in diameter, because these patients will not get off the table unless we do something for them. Those which go off directly into the chambers, often we can get away with, and the type 5, that is the wire perforations, are to be handled in a different way. Now, our data, we don't get, actually nobody has very, very large database, except for one study. The total number of published cases is less than 1,000. And the largest published series is 124 perforations in series. So generalizations are difficult. Every case is different, but some important risk factors have been identified. And these are the references where we get our data from. 30-day mortality after perforation also has remained almost same, between 8 to 15% over the last 2.5 decades following perforation. Now, the risk factors for coronary perforation are a female gender, the history of coronary COPD, chronic total occlusions, rotablation, complex lesions, because this means that we put in different kinds of devices of different sizes and shapes and try and do our best to get what kind of a result we can get. 14% of all perforations in the cardiac tree are in the coronary tree. Surgical repair, 3% of them go for surgical repair. And in large analysis, the cutting balloon is actually associated with lesser perforation as compared to even the NC or the compliant balloons. Mortality after the initial base treatment used for coronary perforations, a follow-up study of 150 perforations over 10 years shows that covered stents actually have the greatest mortality in the long term, but that's probably because the largest perforations are the ones which are covered by covered stents. So this is not really a telling statistic. Now, this is in, what about CTOs? In 2097 CTO PCIs over 5 years at high volume centers. This is published about 3 years ago. IJCTO 3 versus 2.5 as compared to perforation versus non-perforation. And the risk factors are older patients, previous PCI, RCA being the target CTO, blunt or no stump with the CTO, use of antegrade dissection and re-entry, and the retrograde approach. And these are the important risk factors for perforations in patients undergoing CTO PCI. And this is an example. This is a patient who had a CTO of the LAD. And this is when one fails to appreciate all the information that one gets from the angiogram. you can see that it looks like it is 99%. It doesn't look like a CTO, but see the way the LED is bending just at about 25-30 millimeters distal to the CTO segment. This was not appreciated by the operator, who has put one wire in the diagonal just to, kind of anchor the, and tried to get through with a CTO wire. This is Gaia second. And after getting past this, he did not appreciate the bend and tried to negotiate and ended up with a perforation. Now, once the perforation has occurred where the LED kind of knuckles down in the distal part, the wires were pulled out and he realized that he couldn't complete the case. And so they said, we'll wait and see. But sure enough, the patient had tamponade after about 35 minutes or 40 minutes or so. And this is what happens when one has a free perf into the pericardium. So after initially the pericardiocentesis has been done, after a retrograde injection showed that there was no leak from the retrograde side, a covered stent was positioned into the diagonal from the proximal LED. And that is what was the final result. This is closed it, and then this was checked from the other side. How wire perfs normally, if they distal perf, how to close them is to use gel foam. And this is a simple demonstration. We use a fine cross catheter with another wire and a balloon to block off possible leak of the gel foam into the proximal catheter. The balloon is inflated here, and beyond that into the fine cross, the gel foam is delivered, a mix of gel foam and contrast. And you leave the balloon inflated for about 2 minutes or so, and then deflate, and one can come out after having pushed out all the gel foam through the microcatheter. This is how gel foam is prepared. This is a small 3-way. We use a 1:1 saline, and contrast is connected to the 3-way with a 2 ml Duerlock syringe on both sides. And then this is connected to the microcatheter to deliver. Perforation after IVL has also been reported. I've just shown this slide because a lot of people say that perforation does not occur with IVL. This is not true. It does occur. Long-term outcome of different covered stents is very difficult because all these are very, very different kinds of patients. The important thing for us to remember that mortality is nearly 17.2%. MACE is 35%. Tamponade seed in about 27%. Emergency surgery in up to 5.3%. And there is also another, I've heard several experts saying that it does not occur when we do SVG PCI. This is not the case. It can occur. It depends on what kind of pericardiocentesis, what kind of pericardectomy has been done at the time of the CABG. And there are case reports of horrible bleeds into the mediastinum with perforations occurring in the SVG. So this is something that one must be aware of and must be conscious of during. What happened to our case? This is what happened. Since we felt that this was not a free perf. So the same catheter was used immediately balloon tamponade was done to close this. The second guide was taken, wire crossed across, and through the second guide, which is a 7 French guide, a covered stent has been delivered and the perforation has been closed. And the second stent in the proximal segment was delivered up to the ostium as has been made point has been made. Now, since this covered stent, the entire stent is not covered. About 0.5 millimeters on both sides actually is free from the PTFE coating. So it is important to expand this and close the entry completely. Otherwise, some insidious leak will continue to take place. So both ends must be covered. And one will see that these covered stents come with a RBP of 15, a nominal of 15 and an RBP of 16. They also have to be deployed slowly. It's not like you go up from 0 to 10 or 0 to 12 immediately. They must be deployed very, very slowly, and the edges well expanded and almost invariably post-dilated. This is our final angiogram for this patient. This is our second case, which was a little more dangerous because this was a free perf. You can see that with the first injection itself, contrast is running off into the pericardium, and this is a very dangerous situation. And so immediately tamponade was done. And even in the small time that it was taken to put the covered stent in, you can see that this patient has required a pericardiocentesis. There wasn't even time for a second guide. However, we were lucky and we were able to deliver a covered stent since it had been well prepared prior to that. Calcium is a problem because sometimes if you have a proximal calcified segment, it is very difficult to deliver these bulky covered stents into this segment. Imaging of a perforation, I have taken this case from a long time ago when we used to do the BVSs. For the sake of all the experts, I will show what we have. This is what the angiogram was. It looks like a straightforward mid RCA. It's just a shade of a little bit of tortuosity, but there was no problem. A dilatation was done with a balloon, 320, because those days we used to dilate 1:1 while putting in BVSs. We decided to put 2 stents, and so the first one was placed, and then the OCT was done after post dilatation. And we'll just wait as it comes. You can see the distal part seems to be well expanded, but when we come in, this BVS is just hanging. It is absolutely hanging in the mid RCA and with very, very gross malapposition. We felt, no, this is a problem. Obviously, we can't leave it like this. We know that these are very, very prothrombotic or thrombotic devices. The proximal part again seems to be well expanded. And so an attempt was made to try and post dilate this. For the sake of time, I'm going to go a little fast, and you can see this gross malapposition in the mid part of the RCA. And sure enough, the next injection after the post dilatation shows a rupture and a leak. So this had to be covered with 2 covered stents going from proximal to the distal end after balloon tamponade. And that's what was done. The angiogram was 2 covered stents were used because we had to close both the entry from both sides and completely cover it up. And this is the check angiogram that was done after 8 weeks. And at the end of an year, patient is doing fine. This is another image of a mid-LED perforation, post-dilatation of an incompletely expanded stent. Another one which Dr. Keshav Murthy will recognize, this is about 5 years ago, 2015 actually. This is a patient who had an ostial LED, little calcified lesion, but we managed to do a nice DK crush for him, and that part was fine. But then this is the RCA. This was a CTO in the mid RCA. It was a codominant small RCA, and we got greedy. And we managed to cross it, but there was a little bit of dissection. We said, no problem, this can be covered. When we put a stent, it is going to stop. But then the patient had an almighty cough, and he pulled out all his hardware. And then after that, there was a perforation. Now, this perforation, initially we thought, all right, we'll leave it alone. But then with time, we saw that there was a small bit of collection occurring in the pericardium. So we thought we'll close it off by putting a wire into the sinus node branch and did a balloon tamponade there. But then his P waves were lost and he started having bradycardia. Now this is too small for a covered stent. So this is what we did. We put in one small 2.25 stent. On top of that, sleeved a balloon, put in a second stent on top of it and closed it, created a sandwich, fashioned a covered stent, and then stented from the proximal RCA into the RV branch. And the patient is 5 years post and doing absolutely fine. Now, perforation is a dreaded complication. Immediate balloon tamponade is important. Pericardiocentesis is a technique that everybody in the lab must be familiar with. Covered stents are always to be kept handy. I know papyrus is not available, but whatever is available must be there. Gel foam, microcoils, and fat are the other options for closing wire-based perforation. This is an algorithm for how to manage a perforation, and I have purposely kind of hidden this part which says one must reverse the heparin. As long as one is working in the coronary tree, there is no point. You just cannot reverse the heparin because one will end up with a catastrophic thrombus in the proximal part of the coronary tree, which is a major problem. So in straightforward terms, if it is hemodynamically unstable, first thing is to do the pericardiocentesis and place in some kind of LV assist device. A prolonged balloon inflation immediately has to be done for all. In case there is evidence of continued contrast extravasation, then go to the covered stent. If no, very often these perforations seal on their own, especially small ones, which are septal hematomas like the first patient that we showed. Covered stent implantation, one must always check. And if one has a collateral which is ruptured, you must check it from both sides and ensure that whatever CTO perforation has occurred is not leaking from the opposite side, because that also needs to be closed. Careful angiogram review. Is this segment intramyocardial? The vast majority of perforations that I have seen occur in the mid LED, and that's because we do not appreciate that a significant segment of the LED is intramyocardial, and we try to post dilate that with a compliant balloon. Liberal use of imaging, especially if calcified, will always help. Careful wire manipulation, especially CTO wires and coated wires. Bed must be prepared well before stenting. This does not mean, because most of the time it is a stent with fractures at the edge of the calcium and the normal segment, and that is what perforates and tears through the vessel. So it's a good idea if one prepares the bed well, one will understand what is happening to the lesion, especially if imaging is not being used. Always use only an NC balloon for post dilatation. The stent balloons are often very, very compliant, especially the ones which come from Medtronic. They're extremely compliant and they will go to very large sizes very, very fast. Calcium and rotablation, vessel size for burr sizing. Anatomy curves are bad for rota. The point that was made by Dr. Keshav Murthy, if the burr does not go, it is important to see why the burr is not going. Is it because it is creating a false track on the side? This very often occurs if there is a bend. If the wire is kinked at the bend, it is a good idea to remove, put in a fresh wire. Sometimes the burr itself becomes a little dull, and you just change the burr to a new burr and it will walk through. Wire bias to be remembered. And if the calcium is eccentric, imaging is mandatory to see whether we are burring through what we need to burr or we are burring through the normal segment. After the rota, image always. In fact, in our lab, our first imaging is done after the rota because most of the time imaging catheter will not cross before. Cut and modify further. It is better to cut and to use angioscalp and angioscore and make the vessel a little dilated. The advantage of these balloons is you don't have to go very high pressure. So you don't subject the vessel to so much of trauma. Post dilate only with non-compliant balloons and calcified vessels. Thank you for your attention, and I should be glad to answer any questions.
Thank you, sir, for an excellent presentation. You said something like the fracture of stents is the reason for perforation. Is there any specific stent which you use which has got a very good radial strength, which will not fracture and perforate?
I think we are run out of time, and Dr. Chandramani is reminding us of the time. So I think we let him go, and I'll private message you, Dr. Keshav.
Okay.
No, Ajay sir, you can go ahead. We have another 2-3 minutes or 5 minutes in box 2. In box 2, until it cuts off, you can go. But anyhow, before it gets cut off, I'll thank all of you for an excellent discussion. And both the moderators, as well as all the expert panels, as well as the presenters, everything was good. And special thanks to Ajay Sami sir to accept this last presentation in the last moment also. I think you can go ahead with the discussion, sir.
Right, sir. Actually, rather than the type of stent, it's the lesion. If the stent is half in calcium and half in normal segment, and then one tries to dilate it, it fractures at the edge. It's not just about the radial strength, sir. It's about the lesion. The lesion gives way in the normal part and does not give way in the calcified part. And that is where the stent fractures. Nowadays, all the stents are thin strut stents, and whatever you do, they will bend and break and do whatever you like with them. But definitely some stents are more prone than others. The names we will mention offline.
Another question, Dr. Saritha Rao was telling IVL balloon has ruptured, which first time I'm hearing.
No, it's very common.
Did it rupture at 4 atmospheres?
It's all uncommon. Keshavamurthy, everybody has presented on IVL. Lot of them keep saying the balloon bursts. In fact,
Yes.
it seems to be a common event than an uncommon event.
The preparation has to be perfect. If there is any air in the balloon, then the likelihood of rupture becomes very high.
Yes. No, and the interesting thing is that now what we have started doing is that we only take the IVL balloon up to 4. The chances of perforation, rupture of the balloon always is more when you go up to 6 after delivering the pulses. So nowadays we take it up to 4 and we don't go up to 6 anymore because there's no point using that balloon as a dilating tool. The only point of using that balloon is to deliver the IVL pulses. So at 4, I've had less ruptures than when I was going up to 6.
And I think we should not make a lot of efforts to somehow get the IVL balloon to the target location. You should do every exercise to facilitate delivering the IV, because that process itself damages the IVL balloon is what I feel. If you don't do a rota, if you don't do dilate well, the IVL balloon should be a smooth cakewalk into the target area, then it may not actually rupture. The more you use guide liner, the more you thrust the IVL balloon inside, that process itself probably hurts the balloon, is what I feel.
Yes, we should never, have a fight or a struggle to push the IVL balloon in. The bed has to be well prepared for the IVL to come in. It's only when we have this circumferential calcium in a larger sized vessel, we don't have any spicules or anything which are going to damage the balloon. That is the time that you have to take it in smoothly. If we are going to have a very tight lesion, it's always better to do rota before we take in the IVL.
Correct. Point well taken.
And in that case, Nadraj, an imaging prior to this thing will help us to tell whether this lesion is good for an IVL or not. The imaging can tell us whether an IVL is required, whether the IVL is going to do the help. And as you rightly pointed out, you should not get the IVL balloon somehow there.
Jadika, now that you have said that the imaging helps in predicting the response to IVL, can you tell a few points in your experience how imaging actually helps in this particular aspect? IVL is useful. concentric more than 500 microns is what you're expecting to say.
The thickness, it is the thickness. If the thickness is more than 500 and the length is more than 5 millimeter, and you have adequate size of the lumen to put the IVL balloon with a 1:1 artery to balloon ratio, that is the place where IVL is going to do the trick. But if the thickness is less, if it's only at 300 micrometers, or other balloons can do, cutting balloon or scoring balloon will help. But more than 500 microns and more than 5 millimeter in length and an arc of more than 180 degrees, it is better to use an IVL balloon. And of course, as you said, the IVL balloon has to go through the lesion and seat perfectly well there.
Yeah, Keshav, 1 second. The main arena session has already started. And once we are done with this, you people can join over there.
We are done.
And thank you.
Thank you very much for the opportunity.
Okay. Thank you. You can announce it to the attendees also. Fine.
So thank you very much. And so we will now shut shop here and we will go and attend the sessions in the main hall.
Thank you.
For the opportunity.
Thank you all.
Participate in the answer box discussions, not being able to be in both places at the same time.
Correct, sir. Correct. Now you can come to the main arena. We can discuss there, sir.
Right, Dr. Keshav, Dr. Jabir.